Our next speakers is a tag team. This is Erika Pitcher and Dr. Deborah McMahan from the Allen County Board of Health. They have what's called the hot tips on TB for us for this year.
All right. Hello, good afternoon. I'm obviously Erika Pitcher, not Deborah McMahan, unfortunately. At least for my bank account, right? I'm just kidding. So I'm just going to give you some quick updates on some data that we're seeing around the county this year, some of the most kind of hot topic diseases, and let you know the Allen County perspective on that. So first of all, TB, that's what we're here for. As Dr. Nip had in his presentation, last year we had 6 confirmed cases of TB. If you compare that with the year before, we had 17. Just because it looks like a lot less cases, it doesn't mean it's less work. Sometimes we have huge exposures from patients that aren't our county patients, but they expose a lot of people in our county, so it's still a lot of work on our part. For this year, I jumped ahead of myself. Here's a quick snapshot so you can see how our cases are distributed over the last few years. Last year we fell back to about where we should be, between 6 and 10 cases, which we usually see. So all of my data, I always put the disclaimer as to what date I'm reporting that out on because it's subject to change. This number, I submitted this presentation on Thursday. This number is no longer accurate. We've actually had 5 confirmed cases of TB now. It's actually 3 male, 2 females, 3 American-born, 2 foreign-born, and 4 pulmonary, 1 extrapulmonary. And our extrapulmonary case this year is actually very interesting. It's actually in the patient's eye. But even though that doesn't look like a lot of cases, just one of those cases was in our homeless population, and we still haven't wrapped up testing for that, and we've tested over 550 people so far in over 5 different locations. So it's been a very challenging summer, to say the least. Hepatitis A. If you aren't aware, we're currently experiencing a huge outbreak of hepatitis A that's linked to several other states. Typically, Indiana sees less than 20 cases a year, and this was as of August 3rd, so I checked this morning, it's up to 364 cases as of last Friday. So, like I said, we typically see less than 20 cases. We're at 364, we've had 1 death, and the hospitalization rate's about 44%. So in order to be considered a case of hepatitis A, it's not only having a positive hepatitis A IgM lab, you also have to have acute onset of symptoms, and then you either have to have elevated liver enzymes, and that's elevated in the thousands, not just 100, 200, highly elevated, and jaundice. So if you have symptoms plus your lab and elevated enzymes, you're good, or symptoms plus your lab and jaundice, you meet case definition. And so with this particular outbreak, what they found, which started in southern Indiana, is there's a few high-risk groups of people that are predominantly being affected, and that's the homeless population, drug users, both IV and non-IV drug users, men that have sex with men, or we refer to them as the MSM population, and then people that were either currently or recently incarcerated, and then of course anyone that was a close contact to a confirmed case. So locally, what we have seen here is basically less than 5 cases every year, less than 4 cases every year. And again, on Thursday, when I submitted this, we had 11 cases. We're up to 14 in 4 days. So it's increasing significantly. Hepatitis A is here. It is in those high-risk populations, and we're getting 2 to 3 cases every week now. As you can see, the risk factors are based off of the number 11, but we've had people fall into the MSM category, drug use, homeless. One of our new cases will fall into the incarcerated category, and another new case will fall into a contact category. So we are seeing it in our high-risk groups being transmitted. So what this means is we're trying to be as proactive as we can. So the CDC and the Indiana State Department of Health have released 317 vaccine for us to provide hepatitis A free of charge to anyone that meets those categories that I just discussed. So we are being very aggressive. We have, for probably, the last 2 months, 3 months? The last 3 months been going out into homeless shelters, sober living facilities, transitional housing. We've been, every inmate at the Allen County jails being offered vaccine. At our STD clinic, we're offering it to anybody that meets those criteria. Our Allen County Syringe Services Program, we're offering it to all of those participants. Bowen and several local nightclubs, we've held outreach to reach those individuals as well. And that's resulted in 1,700 doses of preventive vaccine being given out this summer to those people. So with the TB in the homeless population and hepatitis A, it's been really challenging because it's not our typical population that we usually work with. So it's really difficult to get these people to come to us. They're not trusting, they don't have a car. So we have had to become very mobile, and we have to take our services to them. You can see some of those pictures. We literally are outside on a street corner. We'll set up anywhere we need to go, basically, so we can just meet the person where they are to eliminate as many obstacles or barriers as we can. One of the hardest things is that second bullet, finding them. So we test them. We'll do a T-spot on them, and the results are positive, but they're homeless and they don't have a phone, and now we have the burden of knowing that somebody is at least infected with latent TB, and we have to find them. So that's been very challenging. And then not only find them, but if we want to treat them, we have to find them at least 12 other times to give them their medication. It's really, really difficult to get people to trust us. I put the most common things that we hear. They think we're injecting them with some kind of tracking device, or that we're going to actually infect them with hepatitis A, or it's some type of government conspiracy. So, it's a big barrier that we have to get over just to allow them, or have them allow us to even test them. And then the other big thing is with our contact investigations, especially with hepatitis A. If you're an IV drug user, I need you to tell me who you use with, and that's not an easy thing for somebody to admit or to give up those names. If you're a gay male that uses an app on their phone and meets up with people anonymously, I need to know who those people are. So they're very socially challenging situations, and it's hard to get people to be honest. So if you're not honest with us, we can't appropriately follow up and protect those contacts. And then it's really challenging to find people between 8 and 4:30. We have had outreach that started at 5 in the morning. We've had outreach that went until 12:30 at night at the clubs. We are trying to be as flexible as we can, but we also have our regular day-to-day jobs that we have to do, so it makes it really challenging to stretch ourselves so thin for so long. And then the last one is they can be really physically demanding. All of that equipment you see there, we pack that up and we bring it. Tent, tables, we're working in the heat, things you don't think of, like the flies are biting us and mosquitoes are biting us, and so it's challenging, and it really wears on us and the employees after we've been doing it all summer long. I have a few extra gray hairs right here on this temple, I think. So that's hepatitis A and TB. I'm going to talk a little bit. I knew Dr. Steinecker was presenting on the flu, so I wanted to show you the snapshot from Allen County for the past year. To put this in perspective, in 2016, in that season, so the previous flu season, we had 15 deaths. So we more than doubled our deaths. We had 32 deaths reported this year. First death occurred on January 5th. Last death was reported in May 14th, which is really late. Usually we wrap up flu in March. That's usually our latest death. So this season, we kept thinking, okay, it's over, and we would continue to get more flu deaths. The age range was 20 to 101. You can see the breakdown. We had 20 people test positive for influenza A, 9 people tested positive for B, and then 3 people were actually negative. So the way you get counted as an influenza-associated death is you either have a positive lab in your chart at the time of death. It's listed as a cause of death on your death certificate. And then if, as Dr. Steinecker said, your lab could be 2 months old, as long as you never had a break in symptoms, you never improved, then it's still considered an influenza-associated death. So those negative cases had it listed as a cause of death on the death certificate. And then a little over half of them were vaccinated, and then I combined not vaccinated and unknown because even though we couldn't find it in CHIRP, it didn't mean that they weren't vaccinated somewhere, and we just didn't know about it. Hepatitis C, I talk about this every year because it's just not getting any better. As you can see, we've had a significant increase. We started seeing the increase in 2015. That's when we started working to implement our needle exchange program. We had a 60% increase in 2015, and then it kind of leveled off in 2016, and then it increased again last year, and we're on par to stay high 300s again for this year. And then for the people that we call every case of hepatitis C, that's a new diagnosis, and we interview them. And for those that are honest with us, I reported out the percentage of them that report either previous or current IV drug use. And it's the most significant risk factor that our hepatitis C population has. And the last thing, which I know doesn't seem like infectious disease, but animal bites are reportable to us. Summer is the busiest time for animal bites, and we see them mishandled all the time. So I'd like to make sure people that if you work in urgent cares or doctor's offices or the ER and you have patients coming in with animal bites, first of all, that they are reportable. Let the health department know because we will follow up. And two, we are here to help you decide whether or not somebody needs rabies prophylaxis. Rabies prophylaxis is very expensive. It can cost over $30,000 if a patient isn't insured. So we like to only recommend it when we know that it really is necessary. So this is just to kind of see if you have any idea about how many animal bites. Now these are just reported animal bites, so I'm sure this is about half of what actually occurs. But does anybody have any guess? You can just shout it out. And nobody from this table? 230? Over 600 animal bites a year get reported. And you can see here the flow over the years. And so that could be anything as I was putting my cat in her crate and she bit me. If you ever, well, you can't because HIPAA, but animal bites are the funnest thing to read at the health department, just so you know. So we set some of the funny ones aside that we read on sad days because you just can't write some of this stuff. So a few more questions. So the only animal that we have in Allen County that's a natural reservoir for rabies are bats. We have a handful of bats that test positive every year. I put the numbers there for each year respectively. And those aren't routinely sampled. That would be somebody woke up with a bat in their house, they collected it, we tested it. Nobody naturally tests out in the wild or anything. But does anybody know the last year a dog tested positive for rabies? Unknown? And this is in Indiana. 1989 was the last time. How about a cat? 1984. Anybody know when the last human case of rabies was in Indiana? Not that long ago, 2009. It was in southern Indiana in District 10, if you were looking at Dr. Chavis's map. So I put that up there because we'll have somebody call and say that their doctor told them they needed rabies prophylaxis when they were bitten by their neighbor's dog. So there's a couple issues with that. One, we haven't seen rabies in a dog for a very long time. Two, they know whose dog it is. So a dog can complete a 10-day quarantine. If a dog is alive 10 days after it bit somebody, we know that it wasn't sick with rabies at the time of the bite. So we always prefer that if you know who the dog is, you're able to validate that they completed a quarantine. That's always our option. You can get rabies prophylaxis up to 2 weeks after your bite, even longer than that. And so you have time to wait out the quarantine. So what should you do? Obviously wash the bite. If you get bit by a dog or cat, your biggest concern, honestly, is infection. It's going to be a rare situation where we're going to recommend that you get rabies prophylaxis. So wash it, Contact your doctor or vet. If it's your pet, you want to know if they're up to date on the rabies vaccine. Try to capture it, and that's capturing it without putting yourself at even greater risk. So wear thick gloves, use a coffee can or something that it's not going to bite you through. And then call the health department. I took that off myself. But I'm on call 24/7, so if it's after hours, you call dispatch, Allen County Dispatch. I get calls at 2 in the morning. I would much rather you call and we walk through it together and we come to the rabies decision together instead of you sending your patient to get something that may not be needed. And this is available. We have these if you want them. It might be hard to see, but it's an algorithm and it walks you through the level of risk for the animal and then what the follow-up should be based on that animal's level of risk. And then there's also the PEP treatment guidelines. So that's the other issue. Not a lot of people do provide rabies prophylaxis, so they're not familiar with how to provide it. So the same document that has that algorithm on it also has these treatment guidelines on it as well that help instruct you how to administer the vaccine and the immune globulin. And that's it. Any questions about infectious disease? That's my number. Like I said, that's Monday through Friday. If you have after-hours numbers, or after-hours questions, you call that number. That's dispatch. And I usually call back as soon as I get the calls. So I would, like I said, much rather you call me. If it's not an emergency, I prefer not in the middle of the night, but it doesn't really matter. Any questions?
Well, you said the hepatitis A outbreak is multiple states involved. Do they know where it's coming from, or is it restaurant-based, or?
Well, it started on the West Coast. There were a lot of cases in California. There was actually a high percentage of people dying in California, and it was in their homeless and drug use population. Then we saw it in Louisville, which then spread to southern Indiana. It's been in jails. It has now, because it's infected people that are food handlers, it has put certain restaurants, affected restaurants. Here locally, we haven't had a food handler yet. I hate even saying that out loud because that's gonna happen. But, so it's hard to say what originated. The major uptick in cases started on the West Coast and the homeless population that also participated in drug use. But what started it there, I'm not really sure. There's a question right here.
Are you working with the other counties around Allen County?
For hepatitis A or for everything?
Hepatitis C is, because I know we've got a problem in Kosciuszko County.
For hepatitis C, she's asking.
No, we don't, as far as, each county is responsible for their own cases. People in Kosciuszko County, if they have IV drug users, they're welcome to come to our needle exchange program. It's not just for Allen County residents, but as far as any other assistance, they could come to our clinic to be tested, but we only follow up with the cases from Allen County. It's such a high disease burden. The same staff that does all these other diseases also does hepatitis C, and so it's myself and Laura, and then 3 other people. So there's just 5 of us, and then obviously we have to get the whole health department on board sometimes, but it's a small staff, so we just stick with our own county residents.
You had mentioned 317 vaccine. Could you tell us what that means?
Dr. McMahan might be able to speak a little bit more eloquently.
It's free vaccine. It's allocated. It's vaccine that's provided free to the counties. Typically, it's for the uninsured folks to be able to be vaccinated. Usually, it's directed towards childhood vaccines, but in this case, they're redirecting it because of the hepatitis A vaccine. So we're able to give it to people who are uninsured or don't have Medicaid or anything like that. So it's been very, very helpful.
Yes.
Was there another question?
What specific things are you doing for people when going into food handling jobs or other things like
Yeah,
either-
so we have to be very careful because it's not a recommendation from the CDC or the Indiana State Department of Health that food handlers are at a greater risk for hepatitis A. So we can't say that we recommend that they get the vaccine, but what we are doing is our food protection division, Dr. McMahan has crafted a letter, and it's going out to all restaurant owners and managers, notifying them of the outbreak, the cost of one case of hepatitis A in their restaurant, and letting them know that if they're interested in getting their employees vaccinated, the health department is willing to either come to the restaurant to vaccinate or they could come to our clinic. However, if they don't meet those criteria, they do have to pay, and we can bill insurance. So we're trying to be sure people are educated, but the only people that we can proactively say need the vaccine right now are those 5 categories that I talked about on my slide. I think one case in a restaurant, do you remember what it was, like $20,000 it could cost a restaurant
gosh,
at
yes.
least? Yeah,
At
so-
least. At least.
Yeah,
Any further questions for Erika?
thank you.
Okay, thank you, Erika.
Well, for my talk, I wanted to talk about some things that we've come up against this year that really are making our jobs, as Erika outlined, fairly difficult. And it's not going to be long. If you haven't already experienced this, you will. And I want to kind of talk about something to kind of pull things together for you. So I want to talk about what I call the new epidemic. And yes, I'm in the process of legally changing my name to Dr. Debbie Downer. I notice that I'm being invited to fewer and fewer parties, so I figure my reputation is preceding me. But actually, we are in some really pretty serious times, especially for healthcare. And you may think that if you're an infectious disease or something like that, you may be kind of removed from it. But I'm going to, hopefully by the end of this talk, you're going to see where you're coming up against, as we are in public health, how all of these things are now dovetailing to create a scenario that's really creating quite a difficult environment for us to do our jobs, to do business as usual, and really for us to get control of this. You know, it's easier, I'm so glad to be talking to a medical community. Usually I'm talking to a lot of like public officials and business leaders and things, and I think in medicine we really have all had the experience where we know that there's a continuum on which every disease occurs. And we know, we've seen it, we've treated those people, that they get to a point and there's nothing we're going to do to change that course. That outcome is just going to happen no matter ECMO, doesn't matter what you can throw all the antibiotics and the antifungals and this and that and ECMO and everything, and they're not going to make it. I'm not sure where we are when you apply this to the situation, the epidemic that I'm going to talk about now. I am concerned that we're getting to a point where if we don't change the way we do things now, we're never going to be able to get this under control. And that's why I thought it was an important opportunity to kind of bring it full circle back to medicine. I have actually a really funny Debbie Downer video, but I'm not going to show it in the interest of time. It was actually pretty funny. But what I want to do is just a little bit a reminder of what Erika was talking about, and then I really want to talk to you about these factors that I think are really influencing at least our ability to do what needs to be done, and I can't believe it's not affecting yours as well. So as Erika mentioned, and my hat's off to our team, they have done a yeoman's job really since, February or March, really. We have just been inundated. First we had TB and a homeless guy who was a spice head and was in jail, in and out of jail multiple times, and had the most infectious type of TB, laryngeal TB. Then followed by the whole hepatitis A thing. For 2 years I've been trying to tell people our STIs are off the hook, and they are really continuing to increase this year, not just chlamydia, but gonorrhea. And I don't know, I'm from the old day when gonorrhea was just the clap, you know, it was just kind of like the worst, you know, and we're seeing so many people that are co-infected now, they have chlamydia and gonorrhea. And more importantly, it's happening in people who are trading sex for drugs and people who are sex workers, and we're seeing that in those folks. We're seeing syphilis. Thankfully, we've not seen congenital syphilis here, but nationally, that's a trend. Congenital syphilis is back. And the one thing that I never hear anybody really talk about is HPV. And I tell you, That if you're sexually active now, you have HPV. That's just, and when they started talking about HPV, it was half the people who are sexually active have HPV, and now it's if you're sexually active, you have HPV. And what's sad is that we are not taking advantage of the vaccine, because we all know that once you're vaccinated, I think you have to complete the series before it makes you promiscuous. But we all know that having been vaccinated with HPV makes you promiscuous, just as being vaccinated with tetanus makes you go out and look for rusty nails to step on. So, but seriously, 26% of the boys in Indiana have finished the series. That's how bad we are. And HPV, it's not just the warts, which are terribly disfiguring and embarrassing to people, but it's all these cancers that we're going to be seeing. Great, we've got cervical cancer under control, but what about anal, head and neck cancer, vulvar, penile, all those things. So I say that because I'm going to be long gone, but you need to figure out how are you going to add that into your screening now, because I don't know how, anal paps, Dr. Steinecker, except for people with HIV, I'm not sure that we even have any recommendations. So all these things are going to have to be developed in the context of all this other stuff we're talking about. And then hepatitis C, thank God we have a syringe services program, because I can't imagine what our numbers would look like without that. And then TB, one case of TB in a homeless person, or someone who, as we just now recently had again, someone who's been through the healthcare system in and out and wasn't diagnosed until 3 weeks later, is really a burden for all of us. So that's just what we're dealing with here in Allen County in the last few months. And I want to talk about how our routine public health interventions. Some of you have been in drills with us. Some of you went through the hepatitis A clinic that we did. Remember that? Was it like 4 or 5 years ago? We had the hepatitis A drive-through clinic. I think we need to practice, because it's just a matter of time before we're going to have to do that again. But all of our typical interventions weren't available this summer. They just weren't working. And I think that's because there's a non-infectious epidemic that is really causing a lot of problems in our community that are actually really affecting our ability to do our work, and yours too, I would guess. And I'm sad to say, and if you've heard me talk about this before, feel free to take a nap or plan what you're going to have for dinner. If you haven't, I think this is really important to know, because it really does affect us, our community, and the practice of medicine. And actually, this was a study that my husband, who is not a medical person, he's in fact a lawyer, said, you got to read this public health study. And when I read it, I was surprised that it was actually a very well done study done by 2 economists from Princeton University. CDC knew nothing, or was speaking nothing of this. And in fact, what they were saying was that what they had noticed was that since the late 90s until now, that people in middle ages of life in the United States were having increased mortality. And you can see it here, the red, that's the United States, and people 45 to 54, with mortality increasing in the face of every other country where it's been decreasing. And if that's not bad enough, think about it, that's during my tenure as a physician. And think of all the things that we've done, the vaccinations, the seat belts, the this, the that, all these things we've done to change that mortality rate, and yet this population is dying at an increased rate. And what they identified that was due to, just 3 things: suicide, drug and alcohol poisonings or overdoses, and chronic liver disease and cirrhosis from alcohol and hepatitis C. Those 3 things were responsible for all of that increase in mortality in that population. And I'd read about this, say, a year ago, and I started including that into some of my talks. But a few months ago, I ran into this slide in another article that they showed, and I thought, man, this has been since I've been health officer. Look at how that map has changed with people. They call them deaths of despair, because again, they're due to suicide, drug and alcohol addiction. And look how that had changed just in the time that I've been in this job. And so when I looked at our data this year, when I looked at our suicides that happened in Allen County, you can see we had a 44% increase in 2017 in the people who committed suicide. And a lot of people think, well, that's the old guy gets his shotgun and goes out to the woodshed and kills himself. No, these are people that look a lot like the people in this room. They're middle-aged. The average age was 40, white males. That's who's killing themselves in Allen County. And this just shows you the average age was in their 40s, early 40s. That's leaving behind a lot of families, a lot of work, a lot of colleagues, a lot of family. The more frightening thing is that when you look at where the vast majority, 80% plus of the suicides occur on average, it's in people who should be working, should be supporting their families, should be paying taxes and paying for my Social Security. These are the people that are killing themselves, right? Well, this is not sustainable for a community, much less a country. And then the really staggering thing is when we look at Allen County suicides, almost every year, at least 1 in 5 or 1 in 4 of those suicides are in young people. So I want to talk about the drug crisis, because remember they said suicide and they said drug and alcohol poisonings. And just quickly, because some of you may not deal with this, I think it's really important to acknowledge that we're talking about two populations of folks now in this day and age when we talk about addiction. We're talking about the typical person that people think of, probably had a bad childhood, a lot of access to drugs, a lot of undiagnosed, untreated mental illness. By the way, what do you think is the average age of onset of depression and anxiety? What age? 14. How long does it take that kid to get into treatment, diagnosed and treated? 8 to 10 years. Is it any wonder then the average age of addiction is 15, right? So these are the people, I think, what we typically think of people who are going to be addicted to drugs. This is what we think of. But we also have another group, an iatrogenic group, people that you and I wrote the prescriptions for when we were all concerned about ending suffering, ending pain. No one should have any pain. The pain scale was one of the 5th vital signs, all of that. Well, we got a lot of people addicted to those medicines. And then we got smart. We realized, oh my God, they aren't as effective, they aren't as safe, and they're more addictive than we ever thought. So boy, we're not going to write those anymore. So we stopped writing prescriptions and we didn't offer treatment. So what happened is these people went to the streets. And now these are the people that are shooting up drugs. They go out, and initially when their doctor won't prescribe them anymore, they'll go out and they'll try and buy the same thing they were taking, prescription on the street, but that's too expensive. They can't afford it. So it's not too long before they go to heroin. And it's not, they're never going to be a junkie, of course. They're just going to, snort it or smoke it. But, again, that tolerance builds such an economic debt that what they end up having to do is just take more and more, so they end up intravenous. And those are the people that are doing all kinds of things to be able to pay for their drugs, including trade sex for drugs. And so when we look at overdoses, again, looking at those deaths of despair, when we look at non-fatal overdoses in Allen County, in 2016 we had 804, in 2017 we had 1,200. Right? And what this map is the EMS runs, and it shows you there's no zip code to confine this to. This is everywhere. These are people that look like you. I was at a meeting the other week, and someone said, well, what's the new face of addiction then? And they said, your daughter. So this is who we need to be concerned about now. And when we've been collecting data for the past several years, so now we have 10 years of data to be able to look at overdose deaths in Allen County. And I can tell you in 2017 we had a 44% increase in people who accidentally died of a drug overdose in Allen County. And we're on par right now to probably equal those numbers again this year. So why am I talking about all this stuff? How does this have anything to do with infectious disease? Well, stay with me, okay? What I think their study really identified was really sort of the tip of the iceberg. We're looking at the end product of long-term despair for most people. People who have undiagnosed, untreated, garden variety depression, anxiety. Some people do have more sophisticated PTSD and bipolar and schizophrenia. But I think what we're talking about is an epidemic, if you will, of a treatable, that's the sad part, treatable medical problem, just depression and anxiety. And again, the World Health Organization says that depression is the leading cause of disability in the world. Okay, and they've been saying that for years. So this problem is only growing. And you can see that Indiana has a fair amount of depression when we're ranked by state. And again, that's old data. So here's where it starts to become a problem for us, okay? Because we know now that we have dynamic ways of looking at what's happening in the brain when we're thinking and when the different situations. We know now that this epidemic is different than, say, something with diabetes or even flu, because when the brain is affected, when that's the end organ affected, people think differently, okay? People tend to get a little bit stuck. They're a little bit resistant to the ideas that we suggest. How many people have ever talked with somebody depressed and they're not doing anything that you suggest? Everything's a yeah, but, yeah, but, yeah, but. Well, a lot of that is biologically driven. Okay, some of that, yeah, may just be their perverse and that may be their nature, but a lot of this is biologically driven. That makes it really hard for them to do what we're asking them to do when it comes to simple things like even just getting a vaccine, let alone some of the more difficult things like going into counseling and exercising, live right, love your mother. Substance abuse is even worse because that not only impacts your limbic system, your mood, but that affects your judgment. Okay, that affects your ability to predict the consequences of your behavior. It affects your ability to make good decisions. And we know that because we know where it affects the brain, the prefrontal cortex. We know that about the impact. But we also know it because we've seen all these pictures of all these people doing ridiculous things that any of us would realize does not make any sense while they're on drugs. You know, nobody would inject drugs and then drive a car, right? If the prefrontal cortex was working, right? So again, how does that affect us? What does that mean when the prefrontal cortex isn't working? Well, it means we can't use our old tried and true techniques. I was on a call with another organization and they were saying what you need to do is just go and hand out cards for people then to come back to your office during business hours and tell them that they can get the vaccine and it'll be free. For a lot of these people, if they can't eat it, have sex with it, sell it to get more drugs, or do it, make it high, they're not going to do it. They can't. It's not like they're trying to be difficult. It's not like they're trying to push your buttons. It may feel like that when you're talking to them, but mentally they're not there. And asking them to do those things is like asking them to be taller, right? It's just not within them. Perfect example, and two examples of this in the same setting at our needle exchange program. Somebody comes in, we know they're a sex worker, we test them, gonorrhea, has the pills right in hand, has to take the pills because even though they're there exchanging and getting clean needles, they don't like shots. So they couldn't have the Rocephin that would be the treatment of choice, right? That same person, we give them the pills, they hold on to the pills till after their work week, which is seeing clients, people who live in our community for sex, anonymous sex, until after their work week. So held on to that medicine, knowing you're infected, knowing you're going to be giving it to other people, and yet didn't take the medicine until after that. And we've seen this with the Hep A vaccine. People coming into our needle exchange program, we're offering you a free Hep A vaccine because we're seeing a hepatitis A outbreak in this population. Oh God, I hate needles, no. Or my favorite is I'm too busy. Now they don't have a job, they don't have their children anymore, they don't have anything going on, but they're too busy. And it's very easy to get frustrated by that because here it makes such sense to you. My God, I'm offering it, you're right here, I'm offering it to you free, and they still don't take advantage of that. That's the kind of behavior that we're seeing over again. And it doesn't just have to be IV drug users. Have you ever tried to have a logical conversation with somebody who does spice? Yeah, good luck with that, okay? Because that's not going to happen. So the problem is not only do they not think rationally when we're offering them their treatments, the other problem is when people do not feel right, they're vulnerable to making some really one-off choices, some bad choices. Because the good news is everybody wants to feel better. The bad news is everybody wants to feel better. And if you and I don't make it happen for them, if we don't diagnose people and make it happen from an evidence-based way, they're going to go on this right here. And they're going to feel better. And they're going to feel better faster than you and I can make them feel better, right? Because this is churning 24/7, offering people some really bad anonymous choices. And that's what happens when people don't feel well mentally. They're going to feel better. They want the easy fix. They want to feel better right now, not when I can work them into my practice in 3 weeks and then I'll see you and I'll screen you and we'll do it. We'll get you a mental health referral, but that's in another 3 weeks. That's too long. When this can be, I could have a heroin drop at the Miro Center in 15 minutes, right? But yet I want you to wait 3-4 weeks to see me to get you into help. That's why I'm saying our old stuff is not working anymore. And the easy fix isn't just drugs. It's porn, it's gambling, it's food, it's shoes, I don't care what it is, all of us are vulnerable. And we're especially vulnerable when this isn't working right. And the reality is I Googled how to feel better fast, and I got 220 million suggestions in 0.39 seconds, right? And how long does it take to get in to see you, right? But This is not this whole vacuum. This has not happened in a vacuum. There's a lot of things going into play that's making it even more difficult. So we already have a population that's not thinking really well, that are not poised to make good decisions. And then we have the internet available 24/7, like I said, available constantly, offering something different. And so much of it is anonymous. As Erika pointed out, there are apps that I could download now that would tell me who's right around here within what, a 5-mile or 25-mile radius who wants to have sex with me right now. Now, their names aren't included in that, of course, but all I do is click on them, we meet, we go, we don't talk, there's no names, there's nothing, just anonymous sex, right? But I worry about the people who do the one-off thing. The guy that has a good job, good family, feels like crap, wants to feel better. Well, maybe that is exciting. Maybe that meth, people say that makes you feel good. Maybe I should just try it to see what it's like, right? And they try it. And meth, which is now what we're evolving from, just the opioid crisis that we were in, now what they're changing to is meth. Meth is the most addictive substance you could ever have. It makes you highly sexual. It makes you very prone to making bad decisions, and it's very refractory. There is no treatment. There's some cognitive behavioral therapy, but there's no medical treatment. There's no MAT for meth. And I could get meth delivered here, like I said, in 15 minutes. How do we compete with that? We have hours of business, and this thing is churning 24/7, offering people kids. Back in the day, I had to really work at being stupid, and I was kind of a stupid adolescent, to be honest. I made a lot of stupid decisions, but I kind of had to work at it now. I mean, I had to make sure everybody had gone to bed, raise up my window quietly, sneak out the house. I had to make sure that he parked down the road, and then, there was a lot of work and skill involved in being stupid. Now you just have to turn on your phone in your bedroom or the bathroom, and you can make some of the most dangerous. I mean, we could tell you a story that just happened here that would curl your hair as a parent. And it happened here in Allen County because this thing makes bad choices so darn easy and so hard to recover from. Teens especially, they are so vulnerable. They really are. And they spend 9 hours a day on social media. 9 hours a day. And adults spend 2 hours a day on social media. And let me tell you, people aren't looking for recipes. They're not just looking for help for their homework. They're looking for something that will make me feel better, some distraction that will make me feel better. The cheaper and the more anonymous and the easier, the better. Because feeling good legitimately and authentically is hard work. So again, the internet and the easy fix, a lot of these things that they get into, whether it's this group sex that we're seeing a lot of here in Allen County, you just have to know that there's a lot of swingers going on here. Is it swingers or is that what it, not swingers? Is it swingers? Yeah. Swingers where they exchange, they go into a big house and they all exchange. A lot of that going on here. There are drug-induced orgies going on here in Allen County. And kids get wrapped up in these things. And they may start, the first time you go may be a choice. Oh, just see what's going on. Your second time and third and fourth and fifth time may be because these drugs are not the same drugs. They are much more addictive than what we ever had to face as kids. You could be stupid back in the day and recover from it. You could succumb to peer pressure back in the day and you could recover from it. This is really hard to recover from. And in that, they're making a lot of really dumb choices. And the problem is, you and I, they don't know who they're, when we get a positive lab on somebody, they come into your ER, they come into Ready Med, or they come into the health department and get tested. Yeah, I know they have chlamydia and gonorrhea, but when I ask them who they've had sex with, they don't know. So how do you do an outbreak like that? And I thought this was really chilling. They aren't scared like we were. HIV, when back in the 80s and 90s was, oh my God. No, they think it's treatable now. Yeah, it's not a big deal. That's scary. So now you also have an attitude that's sort of fearless, and a lot of times the drugs make them feel that way, this sort of, invulnerable type of strength. It's really scary. So here we are in the spring and summer of 2018 in little old Allen County, and we're looking at this trend of infectious diseases, and we're now seeing the trend of despair that we've talked about coming full circle, because we have a lot of people that feel like crap. We have an environment that provides really easy access to a lot of bad choices, anonymous opportunities to feel good in the moment, 24/7 availability, and choices that can adapt to change almost immediately. And what I mean by that is these drug cartels in Mexico, They are very, very smart. If you've never read the book Dreamland, you should really read that because it's a very good book and really outlines how smart they are. But what they've done in 18 months has really gone, they realize now we're really getting better at offering MAT, Suboxone, Vivitrol, those types of medications to people who are on opioid addiction. So what'd they do? They switched. Now it's meth. Now they're manufacturing meth. Remember how we used to have all the one-pot meth labs and all that stuff? Oh, that's passé. Now they just ship it up and it's really cheap from Mexico. So now they're doing meth because they know it's more addictive. They know that most people don't overdose, so it's only usually when you overdose that someone's going to be able to offer you help, right? So they don't really overdose, and there's no medical treatment for it. So see how long it takes us to get legislation, and then we want to get a policy, and then we want a clinical pathway, and then we want to educate everybody. In 18 months, they've changed now to where they're still offering opioids, but meth is what they want now, and meth is what they've changed to because it's much more effective and profitable for them. And we're still trying to figure out what to do with opioids. This thing is changing everything. This is changing your job, and if you don't appreciate it, you're gonna find yourself really overwhelmed in a few years. And I just show this because most of us comfortably spend 95% plus of our time dealing with the branches, dealing with the leaves. We're dealing with all the end product. But at some point, we got to get serious. And this is a medical problem. It is a medical problem. Mental illness is a medical problem. There are a lot of things in mental health that have to be done with it, but true mental illness is a biological disturbance, and we need to get good at addressing that, screening for it, doing the medical part of it, and handing them off. Because when we don't, we make them so vulnerable to making a lot of other bad choices. And now there's just so many bad choices, it's overwhelming. When you sit and talk with these folks, there's so much bad going on. It's really overwhelming to even just hear them. So what can we do? Well, the first thing is we have to recognize we're not in Kansas anymore, really. We're really in a new age and time, and we need to be quicker, we need to be more perspective, and we need to realize that our established public health tools, our contact investigations, all of that stuff needs to be looked at differently now because people don't know who they're having sex with, who they're having contact with. We can't do things the same. These guys haven't been doing things the same for several months now, and we'll probably never go back to that model. And looking how we can constantly tweak the model, we need to meet people where they are. And I know that a lot of times people look at that as coddling or you're enabling. The reality is you're never going to get these under control because we're really in an epidemic with a bunch of adolescent people who have no parents. Because that's what it's like when you talk with these folks. When the prefrontal cortex is not working, it's like dealing with a lot of adolescent people because they just don't have the ability biologically to make good decisions. Primary care and emergency room providers, you need to be doing a sex history. You need to be really asking these things because these people we've been on some of the stings. We go out with, we had this bright idea. Why don't we check some of the Johns and the prostitutes for STI? I don't know where I get these ideas, but STIs at the time, So we go on stings with them. When they do their raids and stuff, we go on with them. And I can tell you, those Johns look an awful lot like us, right? They look very middle class to me, right? And you need to ask about internet sex internet sex, online dating, whatever, because that is a huge risk factor for STIs. They found that people who engage in internet sex are people who have a lot of sexually transmitted infections. So that's something we need to be asking. You need to be having these very blunt conversations with people because we can't identify them anymore. It's going to be up to you to figure out these people and get them treated because it only takes a few men going home with gonorrhea and giving it to their wives, and we start seeing some real imploding of that family dynamic too. And we're just adding to the people in despair. So learning to take a sexual history is going to be really critical, even for a Hep A. This Hep A outbreak, I hope you leave understanding this. Hep A outbreak is in IV drug users and men who sleep with men. And some men who sleep with men that are IV drug users. That's who, now it's going to bleed out over time, but that's who this is occurring in. It's not the something from the rutabaga from Mexico and the handlers putting it in your quesadilla. No, this is the population you need to be concerned about now, and those are the people you need to feel comfortable talking with. We need to change our mindset. Like I said, we need to meet people where they are. If we have somebody in front of us, we vaccinate them. Very little chit chat. Don't try and explain why you need to do it. Don't, because they're not interested, are they, Laura? Do they want to talk about the odds and I'm doing this for you for your own good? No, just do it. I need to vaccinate you now, and plop, just do it. Because, I mean, the talking is very overrated with this group of people. You're just going to frustrate yourself. Oh, yes, we get that, but I'm telling you, and you have to address multiple issues. There was a time when they were doing outreach where they were checking a T-spot, they were checking for STIs, and they were giving Hep A vaccine, because those people were all at risk for all those things. So when you have somebody in front of you, it's not, well, don't think they're going to come back in 2 months and you're going to address that issue. Those days are gone for a lot of these people, an increasing number of people. And finally, new communication strategies. And I don't know what this looks like. You just can't reason with them, and you're just gonna upset yourself. You're just gonna frustrate yourself if you do that. You just need to talk like, there's a reason I'm not a middle school teacher or a pediatrician. So this is very challenging for someone like me. But I'm telling you, we need research to tell us, how do we communicate in a way with these folks? Because something will reach them. It's just not treating them like they have a functioning prefrontal cortex, a lot of them. Some people aren't there and they'll be able to understand, but you've got to know when somebody says, I don't want to get a hepatitis A vaccine because I don't like needles, and they're exchanging dirty needles for clean ones, you know then that you're dealing with someone that you're going to have to use a different line of communication. All these anonymous encounters, you need to be looking for those infections and taking that sexual history. So in summary, I hope you can kind of see where all of this is coming full circle, that the patient who is living in despair quietly or loudly, whether they're just mildly depressed or anxious, or they've evolved into, full-blown addiction, their brains are not working as well as they could. And so it's hard for them to engage in what we have to offer, and yet it's a lot easier for them to engage in things that are increasing their risk for STIs, for hepatitis A, hepatitis C, all types of things. So we're in a new era. We need to realize that, and you need to go back and look, what are you doing differently now than you did 5 years ago or even a year ago? They never thought last year we were not doing what we're doing now. What are you doing differently in light of this epidemic? It's only when we go back and look and realize we need to change things, we need to change the infrastructure, are we ever going to get this under control, if we ever can. And now you know why I'm invited to so few parties anymore. With that, I'll answer any questions anybody has.
Does anybody have any questions?
Oh, yeah, remind me.
Thank you. Should we be asking our ED providers to offer Hep A vaccines to these high-risk populations as they come in?
I think I think we're going to have to talk about that, and that's a good segue into one of the things when we first. How many were at the original SIDNAX in the early 2000s? Yeah, remember we started that when there was West Nile, and we started, and it was infection control practitioners, it was school nurses, it was labs, it was public health people, all getting together to address new phenomena. And we did that, and we had some meetings like this, but a lot of it was working groups. And I think we did that fairly consistently until after the pandemic, and then after that I think we got caught up with different things, and we kind of took a different track. I think after that we had another TB epidemic, and we kind of morphed into this. I think one thing we need to think about is we need to get working groups to be able to sort through some of these complex issues, whether it be, should we be doing, because it's not as simple as, oh, you'd think the answer would be yes. Well, but the state wants to be careful in how you're saying things and how you're marketing things and where the pot of vaccine comes from. And to me, there's a lot of information that we need to figure out how to get to you. So for example, if we're going out and we're doing all these T-spots on people that are homeless, it'd be nice if you could, when they're in the ER, look at and see if these people are positive or negative, right? If we have a database. But there's all sorts of legislative issues that we need to address to be able to combat the privacy stuff. And I think when we have a good multidisciplinary working group of people, we can sort through these issues and make sure that the changes are made from a community-wide basis versus just in one institution or another. I don't think these things are going to go away. So the answer is I don't, it's really hard because you have the CDC and ISDH trying to kind of minimize this. I don't know that they're seeing what we're seeing in terms of you know, the population and how they're not really amenable to doing what needs to be done. So I don't know they understand how aggressive we need to be in wrapping our arms around it and doing unconventional things like that. But it really helps if we could have some of these working groups. So you'll be hearing from us if you signed in to see if you're willing to work on. I think we need a flu working group. Because I think H3N2 should be doing more telemedicine with that, with all the other stuff we've got going on. Is that a recommendation that a thoughtful group of people should support Dr. Steinecker in making to Parkview or to Lutheran or whatever? I think we definitely need one for the whole hepatitis A. I think we need another working group for Campylobacter and Legionella and some other things that we're seeing here to make sure that we're all on the same page, we're all testing the same way, whether you're in Kosciuszko County or you're here. So I do want to make, I'm sorry I don't really have it, and we can talk about this afterwards, but I do think we need to bring back SIDNAC to solve some of these really important infectious disease issues.
Wait for it.
The quality things
Wait
that
for
are
it
going on.
so that we can get it on.
Because of the quality things that are going on, things that are, the offices and the hospital are required to do under the quality umbrella, one of the big things is depression screening in anybody who is Medicare age or Medicare eligible. We're finding more and more people, even when you're in a situation where you think that you are trusted, you know, they're going to lie to you about, I'm not depressed, I'm not going to admit that. There is still such a stigma with depression that nobody wants to admit that they're depressed. I mean, they lie on the tests, and, you know, I'm fine. If you look at some of the nursing home stuff that's going on, the STIs there are just astronomical.
Sexually transmitted infections in the nursing homes?
Oh, yeah. Oh, yeah.
Are they being
And
reported?
places like the Villages in Florida,
Oh, okay, not necessarily here in Allen
nursing homes
County.
are really bad also.
Well, I don't, I don't want to be ignorant, but for the patients or the staff?
Patients.
In nursing homes? We'll have to talk about that. I'm getting an image that I,
I mean, it doesn't make any difference if it's young or old. As a nation, everyone has the same problem. You know, we get stuck looking at, well, this age group for the opioids, this age group for, you know, the Hep A, the Hep C. It's not just middle-aged or whatever. We have an issue communicating with our people or with the public, period. And
part of that I think is, well, I think part of it is medicines, because we've been so reluctant to take on the issue of mental illness. And I really try and refer to depression and anxiety all the time as treatable medical problems, because the more you normalize and medicalize that, the less people will feel some unwarranted shame or stigma towards asking for help. And part of it is the way, I remember when I went in for, I think my knee replacement, and you know how I was screened for depression? Sorry, but the nurse asked me, "You're not depressed, are you?" I mean, it's kind of the way that we ask it. So the more matter of fact, the more we just include it in our routine conversations and screenings, the more we normalize it, the more comfortable people will feel. And I think a lot of times, sadly, I think most of that needs to happen in primary care. We need to do it everywhere, but I think where you're going to get really honest answers is in primary care. I've been screening people for a long, long time, and I found most people are pretty honest. Because the people want to feel better. And I think if they know you're not, you know, really, you have the objective intimacy. You are given a lot of grace by people because of that white coat. And I don't care whether you're a doctor or a nurse. People think you have no dog in that fight but to help them get better. And that's good. That's really good. So you can get in there and ask difficult, you have to, you know, you don't want to just, you're not depressed, are you? But you want to start a conversation. You want to be engaged with people. You have a lot of power that you can utilize very effectively in helping people feel better, but you have to take it. And I don't find that it takes a lot of time, because really you're interested in the medical part. You're interested in the screening, talking to them about it, trying to get a feel for it, and then talking about the medical solution to that, which is like everything else, medicine, of course, and then the referral. And like everything else in medicine, it's going to be a dietary referral or a PT referral. This is just a counseling referral. But I think we need to be more embracing of it honestly ourselves and not be afraid to talk to people about it before we're ever going to see a national change. Did you have something?
Deb, do you have any comments on the threefold increase in Legionella cases over the past 4 years?
We looked, we could not find anything in common. That's what I'm saying. I think we need to dive deeper to be able to figure some of these things out, because a lot of times the state will say, don't bother to look at it, but I don't think when we looked at it, we couldn't find anything. Did you find something, Candace?
No. I had another question.
Oh, okay.
You talked about the deaths of despair. Is there?
Google that. If you just Google that, you'll get a ton of articles that will talk about that. And I encourage you to do it, because it's going to affect your practice in some way, if not your family.
Has there been overlay with correlation to economic
Yes.
pay scales, things like that with this, that we could see this trend?
Yes, they really, and I encourage you to read, because because it was done by economists, and they have a bunch of theories. I didn't go into it here, but they have a lot of theories about that. That the high school educated person doesn't have a lot of job opportunities and those sorts of things. So they have a whole explanation. I think it's always kind of simple to think that there's one thing that's causing a lot of problems. I think the more you look at these things, you can see that there's a lot of issues changing who we are. I mean, at the end of the day, you and I know we're just flesh bags of biochemical reactions. I mean, we dress it up and put makeup on it, but at the end of the day, you are just a series of chemical reactions that are happening at all times, right? So there's a lot of things influencing that internal milieu, biochemical milieu. So I don't know whether that's becoming more prevalent, if it's just affected by, you know, economics, or is it more likely just a combination of things that are really making us more sensitive and less resilient? I'm not sure. But they have a lot of really good economic data on that.
Stepping outside of the economic impact that the depression would have, or despair, is Allen County Board of Health looking at any of the faith-based institutions that are working with those people?
Yes, we have an opiate task force, and the faith community is a big part of what we're trying to do. To be honest, there's been in the last year, some real work with having the faith community address and acknowledge mental illness. There's been some reluctance and hesitancy to do that. And I think the Lutheran Foundation has really done some really good work in trying to bring those pastors. They had a great, I forget the name of the conference, but I think it was about 6-7 months ago. They had a great conference bringing the pastors together to talk about this as a medical problem. We're also trying to get them more involved with the addiction crisis, because for some people, this addiction's a beast. I mean, it really is. And for some people, they're really going to need faith, I think, in some capacity to be able to help them get through it. And remember, faith has always been shown. There's tons of studies that show that people are healthier and people have better outcomes when their spiritual needs are addressed, when they feel like they have a strong spiritual health. I'm not talking about religion here. I'm talking about spiritual health. So yes, I'm a big believer, and that's a really important part of what we do every day, is maybe assessing the health, not treating it, not dealing with spiritual health, but at least assessing it.
Dr. McMahan, can we see that funny YouTube thing from the beginning?
I don't know if is a guy up there to do it. I don't think.
No. Anybody up there?
Oh, I don't know if he, What did he say?
I think he's looking for it.
Oh, okay, it's my second slide. Oh, there we go. Yeah, let's end the day with a little fun. And you can just go after the soundtrack. He's looking. I should have warned him.
You're enjoying your day, everything's going your way. Then along comes Debbie Downer, always there to tell you about a new disease, a car accident or killer bees. You beg her to spare you, Debbie, please, but you can't stop Debbie Downer.
Yeah, that's. I'm going to play that now every time I go in, give a talk. Anyway.
Thank you so much. That was a very informative presentation, and it's always great that you can come and give us information. I would like to thank all of those that have helped to make this possible. there is a great group of people in our TB consortium that meets regularly to provide this for our instructors and to include the SIDNAC corporate people in this event. So thank you again for all the work that you do to make this possible. I do want to tag that there is a presentation coming on August 30th. This isn't, I'm just going to say, it's at Lutheran Hospital on the 30th of August, and it deals with human trafficking. So there'll be a outreach program that you'll meet. Alyssa Ivinson from Channel 15 is going to give a documentary of our county and surrounding counties and what human trafficking means for us. There also will be a police officer giving his aspect as far as this being criminal behavior. And then at the very end of the day, probably the most important part, is a nurse from Indiana Victims Assistance who's going to come and help us to recognize what human trafficking looks like in our emergency rooms or even on the floor. So if you can sign up at that same website that's located on your thing, and then please fill out the evaluation, and thank you once again for attending, and your contact hours are on a sheet at the back table there if you want to pick those up on your way out. Thank you again. See you next year.